Institute. This is Omid Hamid. I am a medical oncologist and director of research at the Angeles Clinic and Research Institute in Los Angeles, California, reviewing some of the abstracts at ASCO 2020 as they relate to immuno-oncology and melanoma therapy. In ASCO 2020, melanoma again leads the way in some therapeutic differentiation and helping us understand how to take care of all solid tumors. There are multiple abstracts, but I'll focus on the ones that were most interesting to me. Adoptive T-cell therapy is an up-and-comer in melanoma and will be in other solid tumors, including lung cancer and cervical cancer. Again, at ASCO, Ahmad Cerniak presented updated data on lipolicil, which is a TIL therapy. A central TIL is made and shipped to the therapeutic center. Which was interesting here is in updated data, there's a 36.4% response rate in melanoma patients. Those who had already progressed on standard therapies such as BRAF, PD-1, anti-CTLA-4. Again, it was feasible with acute toxicities, but no significant new toxicities. The majority of these patients were patients who had never responded to PD-1. So this is a therapeutic that is going forward to the FDA based on updated data for approval as a standard. Again, it's being looked at in combination with PD-1 in other clinical trials. Moving on, more data about VEGF-targeted therapies and immunotherapies for melanoma, and most interestingly, mucosal melanoma. Sheng and colleagues, including Zheng Guo, presented toripalimab, which is a PD-1 therapy, with axitinib. This showed in mucosal melanomas where we've had very low response rate in the teens with single-agent PD-1 and about 20 to 30% in combo. Ipilimumab, nivolumab showed about a 48% response rate with a median duration of survival that was significant, 20 months. This is axitinib plus PD-1 and is clearly an interesting target, as we've also looked into Avastin and in combinations with anti-CTLA-4, anti-PD-1. The most striking abstract by Bella Glitza at MD Anderson, abstract number 10008, looked at the therapeutics for melanoma patients with leptomeningeal disease. And this is a poor prognostic subgroup with survival being in months. This was a combination of intrathecal nivolumab along with nivolumab given IV. The majority of patients had also already seen anti-PD-1, anti-CTLA-4, and BRAF targeted agents where appropriate. With therapy, they showed a median overall survival that was increased from what we expected, and there were patients who did well, and one patient had a response. This was intrathecal and IV therapy, which is now in a trial amended to include patients with lung cancer and increasing the intrathecal nivolumab dose, an indication of where we will go in helping our patients, not with melanoma, but also with non-small cell lung cancer, triple-negative breast cancer, and others. So these three were paradigm shifting, but other data presented at ASCO 2020 by Mike Postow, Dan Olson, and Dr. De Silva and others look at dose and regimen, understanding what dose and what regimen is best and where you should go with anti-CTLA-4 and anti-PD-1 therapies once you have failed anti-PD-1. Looking at abstracts 1003, 4, and 5, the idea of shortening the number of doses of anti-CTLA-4, anti-PD-1, the idea of the need for anti-PD-1 plus anti-CTLA-4 and not just anti-CTLA-4 alone in PD-1 progressors. And then the retrospective study showing that combination PD-1, CTLA-4, and PD-1 failures is showing higher response rates than just anti-CTLA-4 alone. So I've run over time. I want to thank you for your time listening. I urge you to go and look at these abstracts and explore further how these affect your practice.